Thank you very much, Jordan. So, Greg?
Sure. My name's Greg Riely. I'm a medical oncologist at Memorial Sloan Kettering. I think as a medical oncologist, I do order a lot of things, and so I've had to click on ignore more than a few times. I got to say, though, if I would have known it cost $4,600, I might have slowed down a little bit and just thought a little bit more. But I think one of the main reasons I'm here is because I work with a number of organizations, including the American Society of Clinical Oncology, as well as NCCN, in development of guidelines. My clinical focus is on patients with lung cancer, and so that's where most of the work I've done around guidelines is. I want to emphasize how guidelines are really provide the underpinnings for a lot of the clinical decision support that we're talking about, and they're kind of the original clinical decision support for physicians. These guidelines take where there's clear clinical trial data, they apply it, and then it takes a lot of those other situations where there is no clear evidence base and uses consensus to figure out what we should recommend in a given situation. These guidelines can really do a good job of improving patient care, in no small part because it reduces the variability of how we interpret data as clinicians. This guidelines generally also serve as an excellent way to educate physicians. Interestingly, if you go to most oncology fellow clinics and you look in the back room to see what as they're thinking about what to do next, they've got the NCCN guidelines up and they're using that to figure out what the next step is. And then, not to be understated, guidelines really also help to support payment for a given decision. So when you're in the clinic trying to decide whether to do X or Y, and you have to figure out whether the decision you make is going to get paid. If you decide to give drug X and nobody thinks drug X is a good idea, it was a bad idea. But more importantly, you're going to prescribe that, the patient's going to try to go get it, and then they're going to find they can't get it, and then it's all going to slow everything down. So I think that's a great example. But I think one thing I'd like to emphasize that you heard from the earlier speakers is timing of guideline development and how important it is that we do this relatively quickly so that when we make decisions, we have the most up-to-date information. And just to give as an example, because it's helpful to have a positive example, I think this is probably one of the best transitions of data that I've seen recently, but it took time. So in June of 2016, there was new data presented showing that a combination of two drugs, dabrafenib and trametinib, have a very high success rate in treating BRAF mutant lung cancer. Now, BRAF mutant lung cancer is uncommon, it's about 1%, but identifying those patients turns out to be an important thing. So that was June 2016. And then in June 2017, so a year later, the FDA approved the use of dabrafenib and trametinib for BRAF mutant lung cancer. So it really became very clear that we had to be testing for this. About a few weeks later, the NCCN guidelines were updated to incorporate BRAF mutation testing. So that one moved quickly. Then ISLAC, or the College of American Pathology, International Association for Study of Lung Cancer, and the Association for Molecular Pathology all have a guideline that was in development at this time. So it actually is just been released in the last month or two, and it doesn't yet include BRAF mutation testing because it takes time for that process to go forward. ASCO was developing their molecular testing guidelines around the same time, and they adopted the ISLAC CAP AMP guidelines, but then they snuck in and added BRAF mutation testing there at the end. So really from the first presentation of data till the majority of guidelines say that BRAF should be tested was about a year and a half. And I think we can all agree that's fast, but we could also all agree that it probably should be faster. And I think that highlights how guidelines really started as kind of a sidelight for professional societies where, they all kind of got together and said, yeah, that's a good idea, we should do that. And so it proceeded on what I'd like to think of as kind of an academic's schedule, meaning they work it into the rest of their lives and they get to it when they can, and over the course of a year they update the guidelines. So I think you clearly need more focus on it, and I think the NCCN is a good example. There's big staffs of people who work to develop the guidelines and update them appropriately. So I look forward to this discussion and see how we can move this forward.